Hi, I am Dr. Felice Gersh, your integrative OBGYN physician, talking to you today about a really important hormone that gets really underplayed, underappreciated as the sidekick and only recognized sometimes as a hormone related to the uterine lining, and that is progesterone, also known as capital P number 4, progesterone, not to be mistaken for fake progesterone, which are called progestins. Those are like okay under certain circumstances, but that's not part of our hormone therapy for perimenopausal and menopausal women. So, what about progesterone? I want to talk to you about the role that progesterone plays in brain health and how that relates to how we prescribe it and use it as a hormone therapy in peri and menopausal women. Because I think lack of really understanding of this vital hormone is causing protocols using progesterone to be completely inappropriate. So let's talk about the way progesterone is most commonly used in the menopause. We'll talk about women who have stopped making hormones completely from their ovaries, not perimenopause. So typically in the menopausal women, most of the practitioners are providing a rather small dose of estradiol, often as a patch or a gel, sometimes a compounded estradiol product, rarely as an oral product these days. And along with it, they are giving most of the time an oral dose of progesterone, typically 100 milligram tablet, or it could be 200. Sometimes people are giving 200. And often along with the prescription come the words, you're going to sleep better with this progesterone pill. Well, you may sleep deeper, but you're not going to sleep better. And you're not going to get a really good, robust dose of progesterone either. Now, why did this protocol even develop? It's developed to treat just one thing, and that's reduce night sweats and hot flashes, which fortunately it can do. And that's not insignificant. I do not want to belittle the importance of diminishing or eradicating night sweats and hot flashes, but it's not going to get you a sufficient amount of estradiol to create adequate growth factors, because the goal is not to have bleeding. No woman really loves having periods, but it's just how we're developed. If we have a uterus and we have adequate hormones and we're like young in the reproductive years and you're not pregnant, you're going to get periods. And if you don't, then you know something is wrong with you. And any woman who stops having periods or has very irregular periods is going to go to a medical professional to say, what's wrong with me? Okay? So it turns out that estradiol is very important for growing things and replacing things and restoring and maintaining and rejuvenating. And in order to have that happen, you have to have an adequate dose. Everything is dose related. But if you don't want to bleed, then you have to just do what you have to do if that's your priority. And for some people, that may be the priority, in which case you give a very small dose of estrogen. Then progesterone is given as a pill, and it's given every day because progesterone, as one of its features, it downregulates the receptor called alpha of estrogen, and that's the receptor involved in growth factors. So you're going to not grow the uterine lining. That's the goal. That is the whole goal of giving this regimen. But that's not my goal. Maybe that's your goal. I never tell people what their goal should be. But if your goal is optimization rather than just try to suppress a few symptoms like night sweats and hot flashes, and you're going for not the lowest dose, but rather the most physiologic that's aligned with how nature created women, then that regimen won't work. But let's talk about the progesterone part more. So why do I not like oral progesterone? Well, and I don't like taking it every night. And now it's important to know that, and this gets very complicated, and I don't want to go into the whole thing at this time, but to know that if you give enough estradiol, you're going to grow the uterine lining. And I've said this a million times, if you grow it, you must shed it. You can't just unendingly keep growing the uterine lining. And progesterone in a healthy reproductive age woman is not produced every single day a little bit. That's not how it works. you make progesterone and it goes from low after ovulation, it peaks, it plateaus, and then it comes down if a woman isn't pregnant, and then it drops off completely, and also the estrogen drops off, and that induces the bleeding and the expulsion of the uterine lining. That's what it's all about. Clean out the uterine lining to have another try at pregnancy. That's what it's all about. That's the prime directive of menstrual cycles, is to create pregnancies. So progesterone, of course, is preparing the uterine lining for pregnancy. But what else does it do that has to do with brain health? Well, progesterone is a neurosteroid. That means it has activity in the brain. Well, it turns out that there's another neurosteroid that is a metabolite. It comes from progesterone, called allopregnanolone. Allopregnanolone is made in the liver as well as in the brain and some other locations. When you take oral progesterone, it goes through the digestive tract. It ends up in the liver. The liver is the master organ of metabolic transformation. It converts up to 90% of the swallowed progesterone into other stuff called metabolites. The dominant of the other stuff metabolites is the allopregnanolone. Well, like everyone knows, dose matters. You know that in everything. Sleep, how much you get matters, how much food you eat matters, how much exercise you get matters, how much toxic chemicals you're exposed to matters. Every dose matters. Well, it turns out the amount of allopregnanolone in the brain matters. When you take oral progesterone at 100 milligrams, you get a conversion 80-90%, closer to 90%, is converted mostly to allopregnanolone. So you get very small amounts of progesterone into the blood. And we're going to talk about what progesterone does in the brain. We'll talk about what progesterone does elsewhere another time. We're going to focus on the brain. So when you get all that allopregnanolone made in the liver from 100 milligrams, it's about 2.5 times the maximum amount of allopregnanolone that would be circulating from a normal functioning set of ovaries during the luteal phase, during the time of the menstrual cycle that the ovaries are making progesterone. 2.5 times the maximum amount. What if you took 200 milligrams, which many women are getting every single night? Then you end up with 5 times, you can do the math, about 5 times the maximum amount you'd ever have circulating. Well, allopregnanolone in the brain, when it's in the right amount, is actually a very good molecule. It's from progesterone, it's not progesterone, and it has its own unique effects. There are now studies being run, and of course we'll stay in touch to go over all the results, looking at the benefits of a functional physiologic amount of allopregnanolone for treating Alzheimer's disease and reducing the incidence of Alzheimer's disease. It is a very good molecule, but the amounts that you get from taking oral progesterone is too much. Too much of a good thing is a bad thing. Dose matters. So you don't want too little, but you also don't want too much. What happens if you have too much allopregnanolone in the brain? Well, we have, of course, unfortunately, limited data in humans, but there is some data showing reduced memory formation. That's a big deal. You want to be able to have memory. Well, why is this happening? It turns out that in the brain, allopregnanolone is an activator of the GABA-A receptor. GABA is a neurotransmitter. It is inhibitory. That means it sedates the brain. It makes you more like brain foggy. It allows sleep. So it has very good effects. You have to have GABA activated to fall asleep. It is calming. Drugs that are called benzodiazepams, that's like Valium and Xanax, Ativan, they're benzodiazepams. They also act on the GABA-A receptor at a different site, but in a very comparable way. And they are sedating and calming. But too much of a good thing is a bad thing. Too much of these benzodiazepams are bad for the brain. So there's published studies showing that constant exposure, like every night, if you take a tranquilizer of this type every single night, it increases your lifetime risk of dementia. So that's why it is not recommended that anyone take these drugs every night for sleep. It doesn't give you physiologic normal sleep. It's a drug sleep, and it's not good for the brain to constantly overstimulate the GABA receptor. Too much of a good thing is a bad thing. Well, allopregnanolone similarly has been studied in rats. In rats, if you have chronic exposure or even intermittent high exposure to allopregnanolone in a rat, it induces rat dementia. You know how they test, like they can't get out of the maze. They're like stuck in the little maze, which they used to be able to find their way out. So the bottom line is we know more about what happens in rats, but we do have data in humans as well. So this is not a good thing because women have way more incidence of Alzheimer's disease than men. If you took 75-year-olds, men and women, you had equal numbers, large numbers, and then you said, of all the people, all the sufferers from Alzheimer's disease, what percentage are the males and what percentage are the females of this large group, equal numbers of males and females, all exactly the same age, say 75. 70% will be women. We don't want to take a chance. I know we don't have tons of human data. I know we don't have long-term human data, and who's going to collect it and how would you do that? Okay, but we have rat data, we have some human data, and we have science. So why would we want to do this? Why would we want to take a medication as a drug in a way that is completely non-physiologic to create a potential to increase our risk of dementia? If you need to sleep, and many women in menopause have sleep problems, there are ways that we can go about helping every woman with sleep problems to sleep. There are herbals, there's a lot of sleep like hygiene, we can do cognitive behavioral therapy. There's many, many ways that we can help people to sleep that don't involve taking like abnormal amounts of oral progesterone at bedtime. Now, what about if you had 200? Well, the risk is probably higher if you just use logic. But once again, I'm not going to give you information we don't have. We don't have a lot of human clinical studies, but we have the science. Now, what about normal amounts of allopregnanolone? And how do you get normal amounts? Well, if you give progesterone to get normal levels in the blood, levels that are comparable to levels, and there's a pretty good range, but levels that are comparable to levels that would be created in like a healthy 23-year-old during the luteal phase, the time of her cycle when she's making progesterone, also called the secretory phase. Luteal and secretory are the same phases. It's the time after ovulation up to the period. That is the luteal or secretory phase when you're making progesterone. Well, in women who are making normal amounts of progesterone, or if you give progesterone not orally, but rather, and hopefully someday it will be very routine to be able to give it through the skin. I hope we'll get more products, but that is not standard at this time. It's available, but not standard. But you can give it vaginally, and even, I know it sounds weird, even rectally. We have good published data, tons on vaginal. That's what the fertility clinics are using. And you get more physiologic levels in the blood. Then it will go into the brain. And of course, a normal cycling woman will get the normal amounts in the brain. When you have appropriate amounts of allopregnanolone in the brain, it's neuroprotective. It's anti-inflammatory. And that's why they're doing studies now. And I hope that they'll be out soon, but there's some reasonable data in rats, and hopefully we're going to get, now there are human studies being done using allopregnanolone. Now, allopregnanolone, I've mentioned this before, is a drug. A synthetic version is a drug that's used for postpartum depression in a high amount for about 2 weeks. And it can really be extremely a game changer for women who have postpartum depression, once again, working through its effects on the brain, activating the GABA receptor. But this is a short-term use. When you use allopregnanolone, the synthetic version, for postpartum depression, guess what? It's a class 4 scheduled drug. It's a controlled substance, just in the same category as sleeping pills like Ambien and tranquilizers, benzodiazepams like Valium and Xanax and such. It's a controlled substance, Schedule 4 controlled substance, with all the same warnings, that you would get on those tranquilizers when you use allopregnanolone as a drug. So when we take oral progesterone, we have to think, oh, I'm taking something that if I were taking it directly instead of by taking it as a prodrug means that you're taking one drug and it will turn into the other drug that you're really getting, that you really want to get and you're getting. When you use progesterone as a prodrug, then guess what? You need to think of it as if you're taking a controlled substance that can affect your brain like a controlled substance, like a benzodiazepam tranquilizer. Okay? Back in the day when I was doing a lot of obstetrics and I would deal with postpartum depression, and I wasn't the only one doing this, we would give high dose oral progesterone to be a prodrug, to get allopregnanolone, to have a similar benefit to the drug, the synthetic version of allopregnanolone that came on the market a few years ago, that's now the main treatment for severe postpartum depression. We figured this out before the drug companies marketed it, that if you gave high dose oral progesterone, you had significant, reduction in postpartum depression because it converts to allopregnanolone in the liver. You can avoid that first pass through the liver by giving the progesterone vaginally, rectally, or even transdermally through the skin. But if you give it through the skin, you have to realize we don't have published data on its effect on the uterine lining. So where to put it, how to dose it, how to concentrate it, and so on, we don't have data. So you're in a data-free zone if you do that. And it's important to know that, we don't know for sure what dose we should give and how to give it. So, I prefer to avoid data-free zones. So progesterone itself is neuroprotective, even not counting its conversion into allopregnanolone. When you have either naturally produced progesterone or you take it in a way that it doesn't go directly to the liver, the progesterone will circulate and it goes to the brain, where in the brain the enzymes exist. It's 5-alpha reductase that can convert progesterone into allopregnanolone. And the brain will do it as it wants it and needs it. We don't need to micromanage the brain under normal circumstances. Now, I say under normal circumstances because if you have a patient that has dementia, they're going into cognitive decline, they have documented Alzheimer's, or they've had a stroke, or if they've had traumatic brain injury, those are not normal situations. So that's where there's research going on looking at giving allopregnanolone in those circumstances and also giving progesterone, but not orally, okay, unless you're trying to get allopregnanolone. But for example, what about just progesterone, not counting its metabolite allopregnanolone? Progesterone in its own right is neuroprotective. It will help with reducing inflammation in the brain. It crosses the blood-brain barrier because it's lipophilic. It can dissolve in fatty substances. So it can easily cross the blood-brain barrier from the blood into the brain. And in the brain, as I mentioned, it's neuroprotective. It is anti-inflammatory. It can help neuroregenesis, so it can help neurons regenerate. It increases the production and stability of what is the insulation of neurons called the myelin sheath. So this is like wonderful and really important. It actually is produced under trauma situations like traumatic brain injury. The brain will actually make more right away in like astrocytes and microglia. It will make more progesterone because it needs and loves progesterone. Also, in a traumatic brain injury scenario or in a stroke, which is like a traumatic brain injury in terms of the effect in the brain, there's an upregulation of different types of progesterone receptors to allow what progesterone is there and is made to help to reduce inflammation. Progesterone is a natural diuretic. If you have injury to the brain from any sort, whether it's a stroke or trauma, like a hit to the head, over time, over the next 24 hours, the brain will swell. Well, it turns out one of the benefits to the brain is that progesterone as a diuretic can help reduce edema by reducing the fluid in the brain and getting it out. And that's why the brain loves progesterone so much. It increases its own natural production, and it will come in from the blood in a higher concentration if it's circulating. So you need progesterone. So in younger women, when you compare their recovery from stroke or traumatic brain injury, younger women do significantly better than males do because of their ability to utilize their own natural progesterone as well. And there's other things, because we haven't talked about estrogen. Estrogen, in the form of estradiol in particular, is highly neuroprotective as well. So progesterone in the brain reduces inflammation, reduces edema and swelling. It protects the neurons, and it increases the health and stability and production of myelin. So progesterone is wonderful for the brain, and its metabolite, allopregnanolone, that's made from the progesterone in the brain naturally as needed, is also wonderful for the brain, increasing GABA for calmness and peace and happiness, antidepressant. It facilitates sleep appropriately, but not in a drug state, but appropriately to facilitate sleep, not to force sleep, not to be a drug sleep, but a natural sleep. So progesterone and its metabolite, allopregnanolone, are wonderful for the brain. That's one of the reasons I say every woman with or without a uterus should be getting physiologic levels of progesterone, the right amount, and then their brains will convert it into allopregnanolone at the right time and in the right amount. And if someone has brain trauma or a stroke, there may be in the future a pharmaceutical use, a medicinal use of allopregnanolone and or progesterone, because we know that in rats it's very protective, and there are studies ongoing right now looking at how to use these vital hormones so that we can have better brain outcome when such things like trauma or strokes happen. So we don't want to have too much allopregnanolone. Too much of a good thing is a bad thing, and too much allopregnanolone may, and we know it does in rats, but it certainly may in humans increase dementia over the long haul, and it can facilitate sleep, but in a way that is unnatural. We don't want that. We want to have natural sleep. We don't want drug sleep, and we want to have physiologic levels of progesterone in a cyclic manner so that it can downregulate progesterone receptors appropriately, but not all the time. We want it to downregulate testosterone receptors, but appropriately, not all the time. If you take progesterone every day you're downregulating testosterone receptors, which will reduce libido. Nature doesn't want women to have a sex drive after they've already ovulated and can no longer conceive, because that's not what sex is for in nature. It's to conceive. So why would we give progesterone to downregulate testosterone receptors? Plus, testosterone itself is important in brains. And we don't, have a lot of data, but we know testosterone does work in the brain and does things in the female brain, and we don't want to downregulate its receptors all the time either. So we love progesterone. We love its metabolite, allopregnanolone. They can be used pharmaceutically in certain situations, but it's not ready for prime time quite yet for Alzheimer's or traumatic brain injury in most cases, but we want to give it in a way that's aligned with nature. Remember my simple thinking, we're not going to be smarter than nature. If we want to be a little bit clever or a lot clever, and even though we lose our hormones in menopause, we want all the benefits and we want to continue using hormones, it makes the most sense to me Simple thinking, we want to replace those hormones to be similar-ish in terms of the rhythms and the levels achieved in the blood, like a healthy woman at the peak of her health, like in her 20s. We don't want to try to recreate something that never existed in nature, giving progesterone orally, having too much conversion to its metabolites like allopregnanolone in the liver, not getting enough real progesterone to actually do what needs to be done, not just in the brain. I'm going to talk about what it does elsewhere in the body in the future. So we love progesterone. It is neuroprotective. We love allopregnanolone. It also is neuroprotective, but you need the right dose at the right time in the right place.